I can just touch upon, and this I really wanted to be a more interactive session rather than us giving a didactic lecture, and I don't want it to be very technical. So it's more to share the kind of what we do and what perhaps you in the community expect from us or from any super specialty hospital, any kinds of problems that you face. So it's more likely to be, I would like it to be more interactive. So again, without being very, very technical, so what are the common things that we deal with in a super specialty hospital, from the neurosurgery and the spine surgery things? So one of the common things that comes to mind, and it is something which I'm sure drives home to everyone, is say head injuries. Okay, so and I'm sure in a populous and densely populated place like what I've already seen here and the rest of the state, I'm sure head injuries and spine injuries is not a very small occurrence. So especially, so when we're talking about the brain and the spine, time is of the essence, right? From the time that there has been an impact either through the brain or the spine, it is very, very important that the person comes to an appropriately equipped super specialty center in the shortest possible time. So fortunately, it being Calcutta, being a big city, we have large private or even government institutions dotted all around the city, and we have very good ambulance services, so the person is retrieved quickly and reached to the appropriate center as soon as possible. But the point I'm trying to make is that the time is very, very important, and of course what follows on once the patient comes to the emergency room is quick early diagnosis. For that you need the best kind of machinery, CT scan, MRI scans, etc. What is also very, very important is very good ICU setup. So patients who are coming with head injuries are frequently in a coma, so they need to be transferred to the ICU as quickly as possible. And after the diagnosis and initially stabilizing the patient, it is important to then make decisions. If it requires surgery in the middle of the night, we are here as a consultant-led service. We provide surgical treatment 24/7. So head injuries and spine injuries, a lot of industrial accidents, falls from height, sporting accidents, patients come with injuries to the spine as well, and that can result in what we call quadriplegia or weakness or complete paralysis of all the four limbs. So those patients have to be treated in a very specific, time-bound manner in a super specialty center, which is what we offer. So head injuries, spine injuries is one very large kind of thing, and it is of course a community-based social problem that I would say. The other thing is that we have a lot is stroke, and I'm sure a lot of you people have heard of, and I'm familiar or have elderly relatives who have suffered from stroke, which is basically it's a medical term for sudden paralysis of any part of the body. That is called stroke. Now, commonly in common parlance, people confuse, when you say stroke, people confuse it with a heart event, right? So, commonly, when you say stroke, it means to common people a heart attack. But that is not the case. A heart attack is a heart attack where there is sudden stoppage of blood flow to any part of the heart. And that is something most people in the community are familiar with, because it is, it is portrayed in the media, you see it in films, and it is something that happens actually quite commonly. But a stroke, which is actually a brain attack, it should be called a brain attack, is when suddenly a person who, say, elderly person who maybe has diabetes or hypertension is talking to you, and suddenly his speech becomes slurred, or suddenly cannot move one part of the body, or suddenly becomes unconscious. Then you have to think about that this person has probably had a brain attack. And a brain attack simply means either sudden bleeding of a blood vessel in the brain or sudden stoppage of blood flow to any part of the brain, like happens in a heart attack. So that is a very large group of patients that we deal with in a hospital such as ours, unfortunately becoming commoner. And the previously common held belief that heart attacks, brain attacks only happen in elderly people. That's how we kind of associate over the years that 60s, 70s, 80s, someone in the family relative has had a stroke and he's bedbound. But you will be surprised, as a result of basically a combination of things, lifestyle illnesses, hypertension, diabetes, smoking, lack of exercise, obesity, all these put together are putting even the younger and younger population at risk of having strokes. If there is one point I would like to get across, and it is not to do with a hospital or what we are doing and the kind of work we are doing, if it is something that I can put forward to the community through you, through the media, is the awareness that our lifestyle choices now are actually determining what is happening to us, and younger.
Most important thing in any treatment setup is patient safety. And we have NABH, and it's also declared a grade A cancer hospital by the West Bengal government. We have infection control and critical care backup. We have evidence-based treatment pathways, and we continuously audit our outcomes. We do self-appraisal. Last year we treated this many patients. How many got good? How many did bad result? Where we wrong in any patient? What can we do so that it is not repeated? That's very important. Accessibility to Dimapur and surrounding regions, there is easy referral pathways that we can create. We can have seamless appointments. You have the Manipal app, you have the Manipal entire ecosystem where you can sit here, open up and get appointment with me online at any point of the day and come down and consult me there. There is continuity of care close to home. Just think about you going to Calcutta, making a trip to Calcutta with some patient. They have reached there 50 minutes, like I flew today, 50 minutes. You take a train from Dimapur, maybe an overnight journey, maximum 36 hours. You reach Calcutta. They have Rajdhani and very good trains from here, which are passing through. You can go to Calcutta. And if the patient is undergoing a treatment, the biggest advantage is that through this online system, the patient books. We already have the history of the patient. We possibly could have given him or her a treatment date. So you are not in the loss. You know the doctor. You go there. You are not in a loss. Okay, you land in Calcutta and then you start taking an appointment. किसको दिखाना है, किसके पास जाना है, उसी में 7 दिन चला गया. And every day you are spending there is adding to the treatment budget. The treatment cost is not only the hospital cost. It's the cost of the guest house that the patient is taking. It's cost of the food that the relatives are having there. It's cost of everything, of the local transport that you are using. So if you are going there with an appointment, you know, okay, fine. If you have online discussion, you have online appointments, you can take online, you can see all the reports, give you a diagnosis. This is the possible scenario. This is the treatment what you need to do. This is your approximate budget, and this is your date of surgery. How comfortable is that? And this is the test you need to do before you come. So you get all the blood tests done, come over, okay, we see you, you know your date is on 20th, surgery date, you come on 18th or 19th morning, you see all the reports, go to anesthesia, checkup done, patient admitted, 20th she is admitted, undergone the surgery, within 4-5 days she is out of hospital, he is out of hospital and comes back home in 7 days. We can channelize this entire ecosystem, and please take advantage of that, because I have seen patients just going, where are you going for treatment? I am going to Bangalore. Doesn't even know which hospital. Where in Bangalore? Okay, this hospital in Bangalore. Whom are you going to meet? Oh, we will go there and find out. That is what generally happens. We are not even aware of the doctor we are going to meet. We will go and find out. So initially it takes 7 to 10 days to do all of that, which can be done online, and you can reach us. And you know, cancer patients, they are lifelong patients. They have to go back for follow-ups and checkups, maybe in 3 months, 6 months, sometimes a year. So, you know, visiting Calcutta by a flight is much easier than going to other part of the country. It's much near. You can go, do your follow-up visit and come back in a day, 1 day. That's enough. So this is our commitment that we provide everything from prevention of cancer, which is very important to early detection. We have an ethical and transparent care system. Whatever is on the table, whatever is the diagnosis, whatever is the international protocol will be discussed with you and will be delivered. Advanced technology is delivered with compassion, and we look towards better survival of patients with what is most important, with a very good quality of life. कैंसर तो चला गया लेकिन जिंदगी बर्बाद हो गया. वैसे जिंदगी नहीं चाहिए. कैंसर भी जाएगा लेकिन the person should get back in society, should get back in profession. That's very important. This is our entire team of the oncology that I have mentioned. So there are 22 doctors belonging to various departments, and all of us come together to take care of patients in a way that is similar to all standard international cancer hospitals across the world. Thank you.
Is stenosed or tight, we open it up with the help of a catheter, and the valve is deployed at the aortic valve, which opens up the tight spot. We have done the highest number of cases of TAVI in eastern India. You see that the valve is opening up at the place of the aortic valve, and there is a opened aortic valve, creating a normal blood flow from the heart to the rest of the body. We all know about pacemakers. That is, pacemaker is implanted in a patient when the heart rate abnormally drops. In addition to pacemaker also, we are doing CRT. CRT is a device which is implanted in selected patients who have a decreased pumping function of the heart. That is, the heart is not able to pump the blood to the rest of the body, and the patient is having different symptoms like shortness of breath and fatigue. He is unable to do his regular work. With the help of a CRT device, what we do is that we put 3 leads in the 3 chambers of the heart: the atrium, the right ventricle, and the left ventricle. With the help of this device, we are able to increase the pumping function of the heart so that more and more blood is pushed to the rest of the body, and the quality of life improves. The patient is able to do his household work, the patient is able to go to his workplace, he is able to do carry out his daily activities without much of symptoms. Now, previously, we all know that what are the components of pacemaker? It consisted of a pulse generator, which was implanted in the body, and there were 2 leads which were put in the 2 chambers of the heart, the right atrium and the right ventricle. But now we have leadless pacemaker. That is, there are no leads, there are no foreign foreign objects in the body. With the help of a catheter through the groin, we are just putting these 2 devices in the 2 chambers of the heart, and these devices are generating impulses which helps the heart to beat at a regular manner. This is called leadless pacemaker. You see these 2 devices, one is put in the right atrium and the other in the right ventricle. These are generating the impulses, causing the heart to contract at a regular rhythm. We have all heard that babies, small babies or adults, that they have a hole in their heart, that they have a hole between the 2 chambers of the heart. So we have a dedicated department to treat these patients with this, to treat the babies born with congenital heart defects. We are closing these defects with the help of various devices. You can see that these are various umbrella-like devices with the help of which we are closing the gaps. We are closing the hole between these 2 chambers of the heart, and thus improve the life of the baby so that it may thrive, it may grow into a normal adult. And last, coming to the conduction system disorders. As I said, conduction system disorder is a disorder of the heart rhythm. That is, either the heart is beating very fast or very slow, both of which are very life-threatening. So we also have a dedicated subspecialty, that is electrophysiology, for treating these heart rhythm disorders. By electrophysiology, what we do is that we identify the point where this abnormal rhythm is being generated, and then after identifying this point, we ablate it with the radio frequency so that the patient will return to its normal heart rate. Of all the diseases that I have talked about, that is, all these heart rhythm disorders, either the heart is beating very fast or very slow or heart attack, all of these lead to the cardiac arrest, which is a culminating event in most of the cardiovascular disease and ultimately the final cause of death. Here comes the role of CPR, that is cardiopulmonary resuscitation, which is very important to bring the patient back to life. So I would like to hand over the presentation next to Dr. Shubhankar Chakraborty, who will talk about CPR.
Loudly and tapping, no response, then don't delay, just have a no respiration. This is the middle is the breastbone or sternum. This is called sternum in medical language, and lowest part of the sternum is the Ziffit process, Ziffit sternum. So you will choose 2 fingers above the sternum, just approximate 2 fingers. It's the approximate. It's in the center of the chest. Then one hand is like this, and another gripping this. Then heel of the hand, just see meticulously, just see very typical, heel of the hand, interlocked hand, heel of the hand over, just over the breastbone, lower half, 2 fingers approximately above the repeat sternum. Now your shoulder, elbow and wrist, this should be in a straight line, and your shoulder should be on the chest of the breast, chest of the victim or the person. Now start compression. So you should not delay, you should start it within 2 minutes and count it loudly, the number. 30 compressions in a set, 5 compressions, 30 compressions, set of 5. 30, 30, 30, 30, 30. Then you can assess whether the patient is responsive or not. If responsive, again back to that, observe closely till the ambulance reaches and shift him or her to the nearby medical facility. If not that, then continue again a 5 sets of 30 compressions. 30 compressions, 5 sets of 30 compressions means 30, 30, 30, 30, 30, 150 total. Huh? Now, 4 criteria of the CPR. Number 1, position, 5 criteria mainly. Position is 2 fingers above the repeat sternum. Here we can feel in our body also. This is the repeat sternum where abdomen starts. So 2 fingers above the repeat sternum. Here should be the heel of our palm and interlocked with the another hand. So this should be the A, and start, then compression starts. How much compressions? 5 centimeter, 5 centimeter, 2 inches. Less compression, your goal is compress the heart, so heart mechanically, so that what heart spontaneously not pumping, you will compress the heart so that heart can blow the blood to brain and other vital organs. Okay, so compression from outside mechanical. So you have to compress adequately. In between compressions, you have to release, recoil the chest. Just practically think. You have to compress the heart, the blood inside the heart will be pumped out. Then, if you have not released or if you not giving the chest to recoil, the heart will not be filled up with blood again. So you have to give recoil of the chest wall and compress again, so that blood filled, blood pumped up. Blood filled, blood pumped up. This you should learn. So, side I have told you that which side you have to give compression. Position of the body I have already told. Third, how much compression you have to give, 5 centimeter. Not very much. You can not less at least. But too much of pressure can cause trauma. But that's different. Ideally it's 5 centimeter. Okay, 2 inches chest compression. That's the depth should be 5 centimeter. Okay, and then recoil in between compressions, and the rate of compressions is 100 to 120. Ideally, they have recommended 120 compressions per minute, or a compression on an average in half second, 2 compressions in a second. Okay, so 5 vital things of compression, chest compression is side choosing, side selection, position of your hand and body. Number 3, compression, the depth of compression, recoil of chest wall in between compressions. That means when I compress, the chest wall has been compressed. So heart is out of blood now. So if we have not released, then the chest heart will not be filled up by blood again. So if I have compressed and then again compress, blood will not be, heart will not be filled up by blood. So we have to release. There are most of the patients inside hospital, they get back, normal heart rate will get. Now start CPR. So first I have selected the position, taking the palm of the sole of the palm, and then position, shoulder is above the patient's chest. Now compression. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 24, 26, 27, 28, 29, 30. This is like this 5 sets of compression, 150. Then only you can check. Hello, are you okay? Are you okay? No response. Then start again. When you will stop CPR? When the scene is unsafe for the rescuer and the victim. Number 1, particularly for the rescuer. Rescuer is extremely exhausted that he or she cannot continue the CPR. And number 3, patient. So, most important is patient becomes responsive. Stop CPR. First, patient responsive. Stop CPR. Number 2, when the scene is unsafe. And number 3 is patient is another is patient rescuer is exhausted. Then only. Now this is the cause. Compression only life support. You have to give it till the ambulance paramedics reach there. Now if there is another person there, you cannot deliver more than 300 or more than 100, 450 compressions. Definitely you will be fatigued. By that time, you can call another one. If there, your quality of CPR will go down. So, you can ask another person to give a compression for a set of 150. At least you can take rest at that time, not the rest. I will tell later on. So, this is the compression only life support. Again, just I am giving from the beginning. Just a person becomes faint, just see the scene safety, take him or her to a safer side, check the responsiveness, call for the emergency help for anybody if there is, otherwise you can call. If you are alone there, then you have to call like mobile or nowadays mobile, everybody. Then you have to call for help or activate the ambulance nearby or any police station. You can call police station also. Where I am alone, here is a person fainted. This is the site. You have to tell the location, nearby location, whatever you tell. That I am here very new, but I can tell that 2 shops, name of the 2 shops there, the name of the road, and in this city, in this way, I am here is person inside on the road is fainted. He or she needs urgent emergency medical management. Then take care. And then, if you can see anybody, and then check for respiration and responsiveness, and start. If responsive, then close observation till the ambulance reaches or medical support reaches. If not unresponsive, start CPR immediately. 30 compressions, 5 cycles, sets of 5 of 30 compressions, total 150 compressions. After that, check for responsiveness. If unresponsive, immediately resume compressions. Now, compressions, again I am telling that lower margin, lower end of the breastbone, that is the rapid sternum, 2 fingers above it, interlocking of the hand, sole of the palm over there, elbow, wrist, elbow and shoulder straight over the patient's chest wall, and so that your body weight can can deliver as a compression. Then start compression. Compression 120 compressions per minute is the goal. At least 100 to 120, not less than 100. 5 centimeter depth, 5 centimeter, 2 inches depth. Recoil in between compressions, and again, and 30, count it loudly so that you or your co-rescuer, he or she can understand that you are doing this much. It's a 3, 4 sets, 5 sets. Now I off. If another person is there. Nowadays, it's in our country there is smart younger generation. Anybody can catch it very easily, and they can save many persons there. I am showing another time, then we will show you a video, and then you can practice and you can do it. Okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now the question rises, why I am giving 30 compressions 5 sets? Why I am not giving 150 at a time? We used to give in clinical practice sometimes, but that's not typical theoretical. In refractory cardiac arrest or delayed cardiac arrest, we usually give 100 or 200 compressions per minute.